we have a lot to cover, and some of it, these slides we will send out tomorrow, as Kelly said. So all of my slides will be made available to everybody. So there's some data slides in here that I'm not going to cover everything on the page, but statistically wanted you to have as a takeaway. So today we're going to cover state of the market, kind of what's an overview of what's going on in the marketplace, and some new things that just happened today that are going to impact us in the future. Some next step for employers, what employers are thinking about, how they're looking at managing costs and trend, and how they're tackling some of the strategies, challenges with strategies being deployed today. Certainly, having the Cadillac tax delayed has helped us a little bit, but it's still driving the need for a strong strategy. And then we're going to jump right into a sample strategy deck so that you can see what elements would go into a very, very robust strategy development. So the next two slides really are from the Mercer Survey. So Trion, my company, is a sister company with Mercer. We're both owned by Marsh, the largest brokerage firm in the country. So I went into the Mercer Survey and updated some of the things, in the next two slides that you can read at a later time, but just kind of set the stage for what the challenges are that we're facing. And not surprising, the picture that it paints is wages are pretty stagnant. Costs for health care are increasing at a high rate. Employee cost share is increasing dramatically with the consumer-directed health plan strategies that are being deployed. And then pharmacy, you can see that last bullet point. We have some alarming, I would almost call it a healthcare tsunami on the way with the specialty drug spend that's going to be facing us over the next couple of years as it is today. And then again, this is all, the second page is kind of statistical data around employee cost share. And then the last bullet point, the spousal surcharges that are growing as a strategy to try to have people with other coverage be on their employer plans instead of the employer plan. And then, of course, I know a lot of the folks that attend the conferences do retirement and benefits, and I really think that you have to look at both in totality because as our workforce ages, people are working longer because they're not quite retirement ready. That's going to impact our healthcare costs and certainly the pharmacy costs. For every year your population ages over the median of 42 years old, it's attributable to 3% in trend right off the bat. So an aging workforce is definitely going to impact our costs going forward. So we're going to take a moment to talk about kind of setting the table and looking at what's driving costs. And it's definitely, right now when we're in the first quarter, so most of our clients renew in January. In the first quarter, what we're doing is taking a look at last year's claims utilization and trying to figure out in 2015 what was driving our costs so that we know what levers to pull in the strategy early in 2016 so that you can go out to market, the beginning of the summer and put some plans in place or clinical programs, specialty drug programs that will help you control your trends on overall healthcare inflation. So we're looking today at, high claimants are driving costs. Unfortunately, in America today, about 50% of adults have a chronic illness and are on some type of maintenance medication. Specialty drugs are definitely on the forefront of our concern just due to the cost and the prevalency. It used to be specialty drugs, which are biologics, were not that well available in the marketplace, and now they are. And then you have the change just in the marketplaces with the hospitals and physicians banding together in ACOs and things like that we're going to talk a little bit about. So all of that is driving our thought process on trying to really develop robust strategies on how to control costs. If you look at the couple of bullet points there, I definitely think that the adoption of the consumer-directed health plans and having the employee or the members have more skin in the game, so to speak, has definitely driven some of the new technology that's come out in the way of, just the availability of transparency tools, the availability and the drive for the carriers to share more quality information and pricing information. So I'm optimistic about that because it really has changed. It's been a game changer in the marketplace, having some additional information be available to the members. The looming excise tax has not gone away. It kind of, not having to address it by 2018 and having a couple of extra years to try to figure out how to get under that tax. It's still a driver in trying to figure out what levers to pull and what strategies to deploy in order to get costs under control. And then you have the large employers are looking at innovations in the healthcare delivery system, which we're going to talk about a little bit as well. So large employers, the Fortune 100 kind of drive the industry because they have the most leverage with the carriers. And they're really, we went to the main conference with the large employers this year, and I think, the items bullet pointed there on this page 6, really are where large employers are focused this year. They're really looking at incentivizing employees to go to high-performing facilities and where they're getting not only the best quality but the lowest price, and definitely looking at ACOs and narrow networks. Interestingly, if you look at some of the carriers, they're actually, several of the carriers now, the largest carriers in the country are actually doing their provider directories not in alphabetical order anymore. And they're trying to put the top performing providers first. So it's not going to be in alphabetical order. It's actually going to be based on quality. And statistically, somebody did a survey and they found that most people pick a physician that if they're in a search in a directory within the top 10 listed. So that's an interesting development as well. And then the reference-based pricing. This really has had a big impact on pricing in the marketplace. So if you implementing reference-based pricing, so if you had a hip replacement or a knee replacement, things that in a certain geographical area have a very wide spread on the cost. So if you go to one facility, it might be $4,000, and another facility is $8,000 for the same exact surgery. Employers are getting wise to saying that these are the, with consumer-directed health plans and employees having the out-of-pocket costs associated with surgeries and medical care, they're actually providing reference-based pricing information. And even some are going so far as to say, this is what we'll pay for a hip replacement, and that's going to be subject to the deductible and coinsurance, and anything over that amount is yours out of pocket if you choose to go to a different facility. So those are becoming more and more prevalent, and I think that's going to help our industry be a little bit more transparent with pricing. So we have a lot of opportunities out there, but definitely changing the way that we think about healthcare benefits and really consuming healthcare. So everybody knows that's been to some of my sessions. I just love the slides. This particular slide is one of my favorites because it really does kind of show what it is that we're managing in human resources with benefits. If you look at the bottom two lines, the light blue and the gray, that's healthcare inflation, overall inflation and workers' earnings, and they're pretty stable. And then if you look at the blue line, the dark blue line, that is the annual cost of healthcare benefits per employee, and then the gray line above that is prior to healthcare plan changes. So this is the gray on the top is really the out of the gate increases that the carriers are presenting to employers, and then obviously when you're tweaking the plan design, putting clinical programs in place, and doing some of the plan management, you can get down to the dark blue area. But overall, you can see that our trend, even at 4.3%, especially with the change in the out-of-pocket expenses that an employee is facing, are pretty significant. So slide 9 is kind of a slide I put in there for giggles because it's just so busy, but this is what we're managing. And I think if you look in the 2020 box, the red one, the excise tax, it's still the most concerning to me. So we're going to skip to, what is it that's working to hold down costs and what are employers doing to try to manage trend. And I'm not going to read all of these to you, but we've taken from the Mercer Survey and from our experience on really the best strategies in each of those categories that employers are using in 2016 to really manage trend. And we're going to talk about a lot of these, the consumer-directed health plans, the mandatory generics, and some of the other opportunities within pharmacy. We are going to talk about data warehousing, and we're going to talk about private exchanges. So we're going to hit a lot in that first box throughout our presentation today. The well-being category is, wellness is just such an important piece to, if you look at the overwhelming 50% of Americans who have a chronic illness, that bucket is very important to incentivize employees to begin to exercise more, think about what they're eating, and really just some of the well care that is going to be expected of our members going forward. And then, of course, the care delivery is the system. So looking at how do we make providers more accountable. We've spent an awful lot of time in the most recent couple of weeks with the PBMs, so the pharmacy benefit managers. When you carve out pharmacy and you let an ESI or a CVS Caremark or an OptumRx manage your pharmacy, we've really pushed back hard on them in the specialty drug area to help us help our clients.
Lopez.
If you can mute your phones, I think, Kelly, it's *6, correct?
Yes, *6 will mute your line. If you've called in on the phone, please go ahead, dial *6. Sorry, Marybeth.
No, good. We're good. So the care delivery category is really managing the networks, managing the carriers. And if you're not meeting with your carrier partners in the first quarter of the year after your renewal and having them look back and tell you what's driving trend, how many ER visits did you have, were they true emergencies, looking at where you're trending high so that you know what levers to pull for the following year in your plan design to control costs, you're missing an opportunity. And there's a lot of new developments that the carriers are working on that could be integrated into your strategy as well. So that's me and my son. My son just graduated from high school last year. And I always put a picture of my family in there because I do think about our future. And when he graduates from college, hopefully, knock on wood, when Nick graduates from college, he will be out in the workforce getting health care benefits through his employer. And I have a feeling that the way that they're going to obtain health care benefits is going to be significantly different than what we've experienced in the past. So it's always interesting not to just think in our paradigm, but the next generation and what they're going to have to manage and what they're going to have to understand in order to manage their health care. So we're going to jump right into, now that we've gotten through kind of the state of the market and what's going on in the industry and what are the things that we should be thinking about, we want to move into what are the key strategies that are driving the carrier market and the employer market on how we're going to control costs going forward. So we're going to hit on all of these individually in the next couple of slides. So we're going to start with consumer-directed health plans. It is something, that has taken hold and really, I think, helped employers kind of keep the trend below 5% for the last 2 years. And it's interesting because if you look at where we were in the late 80s, early 90s, we were in the HMO mode, right, where HMOs were the big thing on the street and they were the answer to all the problems. But it actually created a problem for us with that mentality of everything's $2 or $5, and then, everything else is covered by the insurance company, because it really has given the employees a false sense of coverage. And now we're moving into, you have a $1,500 individual deductible, and you have to have your HSA or your HRA and really use that to pay for out-of-pocket expenses until you get to your deductible, has really changed the way employees think about healthcare benefits, and they want more information, they want more communication. So one of the things that we're trying to do is provide more tools for employees to use healthcare more effectively. So there's been a lot of transparency tools that have been developed, telehealth, doctors, virtual doctors, where they can, go online and get services, get prescriptions over the telephone, get refills. So there's been a lot of new technology deployed. Fitbits are now being used. There are contact lenses for diabetics that measure your glucose levels and send a message to your watch or your smartphone when you get into a situation where you need insulin or need to eat something. So that there's a lot of good technology out there that are helping people make this consumer development work. So I think we're definitely pushing through consumer-directed health plans as being very a mainstream idea in healthcare benefit management. We're going to jump into private exchanges, and I have to say that we have a little poll that we're showing on the screen. So if you want to take a moment to answer that poll, that would be great. And I'm going to get a little bit controversial and opinionated. But I do have some strong opinions on private exchanges. So obviously Trion has a private exchange that's available to employers, but my dad always told us, even when we were kids, always make sure when you get yourself into a strategy or a plan or anything that you have a way out if it doesn't work. And private exchanges are really just that. I mean, you have to think of them in that mentality, because if you move all of your employees into a private exchange and you get big increases for the next couple of years, they're very hard to unwind or undo. So a private exchange really means different things to different people, but a private exchange to me is just a marketplace. And I have to say the millennials and our workforce love this idea because they love to shop online. So what you're doing is you're using an enrollment platform, and you can either, I look at things as two buckets of private exchanges. One, you as an employer can design your own. So you have your carrier, you have a gold, silver, bronze option with different payroll deductions, and people select which plan they want based on their payroll deduction. Or you could go with a private exchange that has pre-developed products and service offerings where your employees go in and choose their benefits. The thing that worries me about private exchanges is as costs go up, if you have a defined contribution approach where you're giving them a dollar amount to go shopping within the exchange, it does worry me that eventually we're going to get to the point where people are selecting or not selecting benefits that they had in the past, like dental and vision, because they want more money to put into the medical plan. And then of course we have the public exchanges, which kind of created this whole idea. And interestingly, hopefully everybody saw the Wall Street Journal today, the New York Times. It was pretty much front page of every newspaper that United Healthcare, one of the 4 largest carriers in the country, has announced that they're pulling out of most of the states in their public exchange offering because they're losing millions of dollars. So it really does, that is a public exchange, but it's going to impact us, because if the government wants to save the public exchange system and you have carriers pulling out because they're losing money due to bad risk, they're going to have to pay more in subsidies for the people that are in the marketplace exchanges to help those carriers stay in the marketplace. And the only way they're going to do that is higher taxes. And the taxes that employers paid into making the exchange viable, I don't think they're going to go away, and that's why I don't think the excise tax is going to go away either. I hope they change the dollar amount, but I don't think it's going to go away because I think that's fundamentally how they're paying for this healthcare reform. So why are people talking about private exchanges? Definitely the Affordable Care Act with the public exchanges drove the conversation, but I think a lot of employers are looking for a way to have the employee almost buy down and give them an opportunity to get out of the really rich plans so that they can avoid the Cadillac tax. So one of the things with many of my clients where they have very, very rich benefits, they're trying to get employees to electively buy down so that they can avoid that Cadillac tax when it comes. And that's precisely how the private exchanges propose to save cost. So they're proposing that when somebody goes into a private exchange, they're looking at their dollar amount and they're being very conservative in what benefits they're choosing, what type of health care plan they're going into, and it's just making them a little bit more consumer-driven and cost-conscious. And then, of course, there's the element that when it's their HSA account that they're using to fund health care, that they're being a little bit more selective about going to the ER versus urgent care, and just better consumers in general. So this is kind of a leave-behind slide, but I wanted to put it in here because there are very different definitions and options in a private exchange. So there's insurance-sponsored private exchanges where, let's say an Aetna will have 6 options on their exchange where, you can buy their exchange and your employees have access to all 6 options with different payroll deductions. There's a lot of tech firms, a lot of brokers and consultants are in the business now. And there's different models because some are fully insured only, some are self-insured and fully insured. So you really have to look at the pros and the cons of each. We're going to jump into the pharmacy management, and I think, Kel, you're going to put up another, there you go, another little voting opportunity for you. So we'll give you a moment to take a look at that survey that we're doing. That's the last one today, but we wanted to see how many people carved out their pharmacy. So pharmacy management, if you look at the total trend of your healthcare spend, pharmacy is taking a bigger chunk of that. And it's become such an incredible high area of cost, especially with the specialty drugs, that it's something that you definitely have to take a look at trend management and all of the clinical programs that you can put in place. So I'm going to just touch on 2 things real quickly. So a specialty drug is a biologic. It used to be that we had flat chemical pills that we took, and now they're biologic. They're living organisms, and that's why the specialty drugs are so expensive. They require special handling. They require special storage, and typically they're over $1,000 a month. So one of the things that we at Trion in our consulting process, we're trying to put a lot of clinical edits, hard stop edits in the specialty drug category. So if you take the PCSK9 cholesterol medicine, when that was developed, it was developed for less than 2% of the population, right? So it was developed for people who are on Lipitor or some of the other cholesterol treatment programs. And this new particular, drug is very expensive, and it's forever. So unfortunately, the $12,000 a year spend, $1,000 a month, is going to be for the life of the patient. We want to make sure that just the 2% that can't tolerate the Lipitor or it's not effective for them are on that expensive drug. So we're looking to the pharmacy benefit manager, and whether you have your pharmacy with the carrier, and that would be your pharmacy benefit manager, or carved out and using a specialty drug company like an ESI or a CVS Caremark or an Optum RX. Those are clinical programs that you need to be vetting through now, because it's easier to get in front of these and tell your employees or members you have to go through a process in order to be eligible for these very expensive drugs, just to make sure that you're making sure that the people that are on these drugs, they're warranted for. So those are the things that we're doing this quarter and trying to set up the plan design and pull the right levers for the plan management. One of the key opportunities, I think, is over 50% of employers now carve out their pharmacy. So if you have your pharmacy with your carrier, I think taking a look at carving it out to a PBM or a pharmacy benefit manager is a key strategy. The reason that it's a key strategy in my mind is because that's all they do. They manage pharmacy. They have a specialty drug arm that just does specialty drugs, and within that specialty drug management company, like Accredo with ESI, they have pharmacists that just do cholesterol medication, and they know everything about the hepatitis medications, the cholesterol medication, whatever clinical category they're responsible for. They can impart to members the side effects that they're going to experience, and the side effects are key in getting people to adhere to taking the medicine. And the quantity management. So we're this year putting a lot of clinical programs in where it's split refills. So instead of a 30-day supply or a 90-day supply, they're getting a 15-day supply of a specialty drug to make sure that the side effects aren't physically inhibitive of them taking the drug and being adherent to taking the drug. So there's a lot of techniques and step therapy and utilization management and quantity control management that you can put into your program on the pharmacy. So on this slide, again, I'm just trying to list the pros and the cons of carving out to a PBM. The challenge of integrating it back into the medical data is really not that tough anymore. Most of the carriers on the pharmacy side can reintegrate the data within a couple of days into the medical data. But it does leave you with some charges, some file feed charges potentially. But again, using a PBM, that's all they focus on. That's what they do for a living. And they really come up with great data analytics of looking at your utilization and coming up with actionable recommendations on what you can do to control your pharmacy trend, which I think are critical in the next year with the specialty drugs. So we're going to jump into life and disability, and I'm going to cover this one pretty quickly because there's not a lot of meat and potatoes to this, but it's such a great opportunity for people who haven't looked at it in a while. The 800-pound gorilla is the pharmacy and the medical, and the life and disability is kind of lackluster, and people don't spend a lot of time looking at it, but it is in this marketplace today. If you haven't looked at it in a few years, there is a marketplace opportunity because rates have become more competitive in this area. So employee absence, when you can control that and take a look at some of the new protocols and enforceable actions that you can put into your plans to manage absence, you can significantly lower your overall cost. So if you haven't, again, looked at some of the new federal and state laws and challenges, and making sure that not only you're compliant, but you have the most effective management techniques and bells and whistles in place, it is a huge opportunity for employers to take a look at this year. So what we do is we take a very integrated approach, and it's very interesting because there's been a lot of studies done on disability participants and people out on disability and linking them back to the high claimants on the medical side. So the next section of our presentation, we're going to talk a little bit about data management and data mining. And it's really interesting when you can integrate the disability information back in with the pharmacy and the medical information, because I think there's very, very strong links into the 80% of your dollars that are spent by 20% of your people, and then taking a look at how many activities are on the disability and absence side and how those integrate and coordinate. So you can see, again, this is kind of a leave behind slide, but if you look at the wheel and kind of look at each step and integrate some of these into your programs, there's a lot of carriers now that have a lot more robust platforms on the disability that really can help you in the lowering the absence and managing your disability costs. And in turn, basically, that dovetails into the medical and pharmacy as well. So we're going to jump into kind of using that data. Again, data warehousing is something that is definitely a lever that's being pulled in the strategy this year. We partner with 3 or 4 different data management companies where we're using our data warehousing or data analytics unit to use one of the data warehousing companies out there to pull all of your data together. So it pulls the pharmacy data from the PBM, it pulls the medical data from the carrier, it pulls the disability information from your disability carrier if you do it internally. So it pulls all of your data together, and it really gives us some fabulous results where you can actually try to figure out, okay, what are your top trend management issues? And interestingly, if you look at the buckets, we talk about how you manage your healthcare benefits, right? So I look at things in 3 buckets. You have your well people with very little claims. You have your prevailing claim bucket, which I personally think is the most important group. And then you have your high claimants, but they're already your high claimants, so there's not a lot of influence that you can have on those other than, maybe some carrier network discount kind of things and medical management to make sure that the clinical case management nurse or the disease management nurse is helping that sick patient through their large claim. So if you look at the data and you categorize it into your 3 buckets, the prevailing claims bucket is definitely the major bucket to look at because those are your next high claimants. And if you look at some of the tools today, it is amazing how accurate they can get with what your next high claimant's going to be and what are the disease categories that you need to focus your programs on. So the data aggregation, the analytics, and then the interpretation of those results and what's driving trend can really help you determine what levers to pull. So we covered a lot just now. I know I wanted to jump into kind of a sample for you where we're going to jump into a sample strategy. And again, my sample strategy is very long, and I'm not going to read every page, but we're certainly going to make these available to everybody at the end of the presentation. And I think what I wanted to do most of all was leave you with kind of a framework of how we build a 3-year strategy, or on an annual basis, what are the elements that we look at. So each and every one of you, we have over 80 independent companies on the line today listening to our WebEx. So we wanted you to have some type of takeaway of what do you do to build a good, strong strategy, and what are the levers being pulled. So we kind of covered the state of the market. We covered what the cost drivers are, what the big things are that are coming that are concerning. We talked about those big ones a little bit in depth. And now we're going to kind of go through how do you use those levers to build your strategy. So of course, I said in the first quarter of the year, you're looking at last year's 2015 claims data, all of the utilization, and trying to figure out, okay, what are the key items that we need to focus on? And believe it or not, it's different for every company we look at. It's just a little bit different. And it's interesting because companies come away with, wow, I didn't realize that was a big issue within the population. So it gives you opportunities to communicate as well as change kind of some of the health management, the vendor management, the employee contributions, and the employee plan costs. So if you have, if you can incent somebody to use an urgent care versus an ER, again, you're going to save money if that's an issue for you. And then you develop your multi-year strategy, and every year you're tweaking the strategy a little bit to make sure that it's still relevant. You're still looking at the claims data every year. We actually look at claims data on a quarterly basis to make sure that nothing's significantly changed, because throughout a year things can change. And we look at it by population segment. So we actually look if you have, divisions, multiple divisions, or employees in multiple states. It's always very interesting to look at the utilization by state, because it does differ by geography, and the cost differs by geography. So we're going to kind of go through these quickly. I'm not going to read every sentence to you, but we look at the benchmarking to see where plans are comparative to your geographical employer competition and your business vertical. Of course, we have to do the payer play analysis. Interestingly enough, at the last conference, we did have one of the presenters talking about payer play and how the tax, to pay the tax and have your employees get benefits through the public exchanges, might be a lot less expensive than paying the $11,000+ per employee for health care benefits annually. But when you take a look at the tax advantage that an employer gets by offering health care benefits, because it's still tax deductible, that actually tips the scale in the other direction. So when you do the payer play analysis, you have to look at the whole picture, including the employer taxes, to make a good, strong financial decision. And then, of course, your demographic analysis to take a look at what your population looks like. Are you predominantly male? Are you female? Are you female in the higher age category or the lower age category? Because that can make a big difference in your claims experience. And, of course, we talked about the aging population and how that plays into everything. And then, of course, we look at your medical and your pharmacy and kind of your health management or your chronic categories or your at-risk categories. And then we look at employee contributions of what, it's interesting because we just took on a new client, I would say middle of the last year, and they had two plans, and one was much less expensive than the other plan. But when we actually did the actuarial valuation of the plans, they were so similar, they were within 1 point of each other on cost. So there really shouldn't have been that big a difference between the contributions. So I think actually doing the financial evaluation of the actuarial plan value is very important. And then, of course, you get your renewal analysis where you're getting the renewal from the carrier, either on a fully insured or a self-insured basis. So this is a sample of a demographic dashboard where you're kind of looking at your population, what plan they picked, what tier they picked, and the age gender factors. And then we kind of go through, okay, based on the utilization data and your renewal, here's what we think your savings opportunity, here are the categories, or this is where the consulting kind of comes in of what we think an employer should kind of consider or look at, and the pros and the cons of each. And so we move right into the 3-year strategy. We have, this year, if you're attending the conferences, one of the 4 conferences that University Conference Centers is holding this year. I think the next one is in Orlando, and then we go to Chicago in June, and then Vegas in September. We will actually be doing a demonstration of our strategic forecast tool, but it's really cool. So we take your plans, and we load your data in by employer, employee contribution, and then the plan cost, so co-pays, deductibles, things like that. And then you go over to the opportunity pyramid, and you can play with things, and you can put in what your budget is. And this is a really nice tool because it can actually show you by tweaking contributions or plan designs or putting in some clinical programs to hold down pharmacy costs, what that would actually do to your overall budget. And so you come up with kind of a 3-year strategy, and if you don't have a budget or an idea of what a company can tolerate, it is interesting to, and we see more and more every day, the C-suite participating in our strategy development because they get it. This is the second cost to payroll now, and they want to understand where are we budget-wise today, and where are we going to be if we do nothing? So the red line is a do-nothing strategy, and you can see they're going to go from $22 million to $28 million if they do nothing. So some tweaks in strategy and plan design changes would be the middle line by year, and then the flat line is kind of where we are today. So at a 0% and nothing changing, this is what the cost would be if you could do that by 2018. But again, that would require significant plan design changes. So definitely taking a look at a 3-year strategy is very interesting. So in this example, we actually did a full program review, we did a plan design review, we did a contribution design review, we did a funding methodology review because this particular client was fully insured, and we looked at carving out the pharmacy and moving to a self-insured platform. We looked at vendor management. Did we have the best vendor in place, carrier? Could we get better discounts? Could we get better clinical management and clinical program, health management programs? Looking at, not only a compliance audit, but maybe a dependent eligibility audit, maybe a medical claim audit. If you haven't done any audits with your carriers in the last 5 years, I would encourage you to do one. I used to work for a very large carrier, and companies that had performance guarantees built into their contracts for accuracy and claims payment, they were put in a different claims unit. So they were put in a claims unit with a little bit more seasoned claims payers, which is really, telling. So you want to get, obviously, the best bang for your buck. So that might be something to consider as a future opportunity. And then, of course, the healthcare reform is a big chunk of what we have to do every year, along with the communications opportunities. So we kind of go through the program review. We review the medical, we review the pharmacy, the dental, the life and disability, and we identify utilization trends and then come up with strategies. So these are, I'm not going to read all this to you, don't worry, but these are just some of the things that we wanted to point out to this particular client, just to make sure that they knew where they were running high and where they could experience some cost savings or what we needed to take a look at. So we jump into, this is just an example of vendor management and kind of looking at the methodology behind, being insured, where we think the insured rate should be based on the claims utilization, so where we think there's opportunity to negotiate with the carrier, and then what it would look like on a self-funded basis. So if you're fully insured and you haven't done the math, with healthcare reform, you should, because just right off the bat, there's probably 5 to 7% that you can save just in taxes if you're on a self-funded basis. And with proper stop loss, it really could be an opportunity to carve out, in this case, it was $1 million. And then, of course, cost drivers, the key drivers from the marketplace, kind of looking at, what are the key opportunities for you. Are you getting 100% of your rebates on the pharmacy? Are you not able to get 100% of the rebates because you've given up the rebates to offset your admin fee, which I will tell you from my experience is never a win for the employer. It seems like the insurance company always wins in that deal. So if you've allowed the PBM or your carrier to keep your pharmacy rebates in lieu of no admin charges, administrative charges to manage your plan, it's probably a 10 to 1. They're keeping, 10 and they're giving you 1. So that is something that, definitely something to think about if you have that set up in place today. And of course, the funding methodology, we kind of go through stop loss, what the stop loss looks like. We've had a bunch of lasers this year on the stop loss due to the specialty drugs where, you're hitting the stop loss more easily now with the combination of the pharmacy and the medical. And I have to say, we do still have clients that we meet with, brand new clients that don't have their pharmacy included in their stop loss, and you need to have your pharmacy included in your stop loss now with the specialty drugs. just a pharmacy claim will easily hit some of the stop-loss spec levels if they're on a specialty drug. And then, of course, evaluating kind of the high-low option and evaluating whether you want to have multiple options in your plan, reviewing just some of the clinical programs that they have in place, like mandatory mail or what your generic rate is and how you can get that up, implementing some of the preferred drug step therapy. We talked about that a little bit earlier. But if you look at just the cholesterol medications, if you put a clinical program in there where they must try Lipitor first or a generic first, Lipitor second, and then the expensive new cholesterol drug medication as a last resort, instead of being able to jump right to the most expensive, those are all very, very good clinical programs. And, you know, a lot of companies that we meet with don't like those programs because it upsets the employees that are on medication today. You can always grandfather them. So you can say the people that are on Lipitor today, we won't force you to a generic. We'll just have you pay the difference. But going forward, any new prescription, you have to try a generic before you move to the name brand. So things like mandatory generics have become more popular within a grandfathered base. And then, of course, the value-based plan designs and the chronic disease areas, these are my favorite areas to delve into. So really looking at your utilization, looking at how many diabetics that you have in your population, and then developing clinical programs around those diabetics. You know, the first thing that we look at is if you have a high number of diabetics, what is their compliance or adherence rate with their medication? So almost all diabetics are on a 90-day supply maintenance medication. And it's really interesting because you see a lot of, 90-day refills at 160 days. So if they're getting their 90-day refill every 160 days, they're not taking their medicine every day. So you can do a lot of opportunities. You can say if you're compliant, you can get your test strips for free, or if you're compliant, you get a 30-day supply or a 90-day supply for a 30-day copay. There's a lot of incentives that you can put in there to get people compliant with their medication. And right now, the rate of non-compliance is very high. And I think that we've determined that it's for two reasons. We used to think it was because people couldn't afford their medicines, but it was actually determined through a number of studies that it was really just the lack of being able to go to the physician to get a new script and get that script to the pharmacy. So there's been things like automatic refills that have been generated in the mail order drug 90-day supply category where they're automatically refilling it and sending it to the member. Clinical programs in place to make sure the member's still taking the medicine, nothing's changed before those are distributed. Those are all key programs in the management piece. And then, of course, some of the more progressive ideas like the high-performance networks, the reference-based pricing we talked a little bit about, the Centers of Excellence programs. I had the opportunity to hear Bob Erie, who's the VP of HR for Lowe's Home Improvement, and they have a very robust Center of Excellence program where for certain high-dollar, high-cost surgeries, they've identified and negotiated with certain facilities for not only the highest quality of care, but the lowest price. So there's a lot of employers out there that are trying to drive people to, the top performing providers. And then, of course, if you're large enough, the on-site clinical and the primary care physician models. Interestingly, I will tell you with my clients, biometric screenings are this year, more and more employers are talking about doing away with biometric screenings and putting the stipulation in to the employees. Over the next 12 months, you have to have a family physician or a primary care physician measure these 5 items in order to get your credit in 2017 for the same credit that they would have gotten for the biometric screenings. And the philosophy or the theory behind that is if somebody is going to their family physician, it's actually better for them than just going on site to get the biometric screenings. They take the slip of paper they leave and they either throw it in their pocket or throw it in their office and they don't do anything with it. We think there's more compelling results if their family physician knows that their cholesterol is high or their blood pressure is high, and getting people to address those issues on an ongoing basis. So that's one of the other prevailing thoughts this year. Contributions, I'm not going to talk a ton about contributions, but as I said earlier, one of the things that you need to really make sure that you're doing is doing a fair actuarial evaluation if you offer more than one plan, and making sure the contributions are set appropriately. And your COBRA conventional equivalents set appropriately to the actuarial evaluation of your plan to make sure you're not overcharging your COBRA participants. I love audits. We talk about audits all the time, but if you haven't done an eligibility audit in a while, and if you have an electronic enrollment process, they're very easy to do. But typically, on an average, you find 3 to 5% of ineligibles on your plan, and those could be cost savings opportunities and hospital bill compliance and audits as well. So, you want to develop a long-term communication strategy, comply with healthcare reform, offering voluntary benefits, especially with high deductible plans, the hospital indemnity plans. Some of the voluntary plans dovetail very, very nicely with some of the newer plan models on the medical side. Just some things to think about. So that is our presentation for today. I actually am thrilled that I got through all of the slides. Kelly, I hope you're impressed. I did get through all of the slides that we thought were 65 slides is a lot. But I am available for questions. We have a few minutes now if Kelly, you want to, if you had any questions come in that you want to vet through. And of course, I'll send out the presentation and the slides tomorrow. So you'll have our contact information as well if you have any specific questions that we weren't able to get to today.
Marybeth, I'm amazed that you got through all those slides. Congrats. We did get several questions in through during the webinar. A couple were regarding what is the kind of defining line as far as employer size that makes PBMs interested in helping an employer carve out their pharmacy benefit. Are some employers too small? Or is it something that any size employer could do?
That's a great question. So the only time you can carve out your pharmacy is if you're self-funded. So fully insured clients are not eligible to carve out the pharmacy. And if you did carve out the pharmacy, you would have to make sure that you have stop loss on the pharmacy. So that's why I'm saying it's not really viable today for a fully insured group to do it, because there's no decent stop loss on pharmacy only. So you couldn't self-fund the pharmacy and have the medical fully insured. But for self-funded clients, I believe that, any company that's self-funded would probably be able to find a PBM that would do business with them. We have a lot of clients that are 150 to 200 employee lives that are self-funded that carve out their pharmacy.
Okay, awesome. Another question kind of regarding that, the stop loss you were talking about. Where do you see stop loss premiums going when RX or pharmacy is incorporated? Stop loss,
Cal, if I was going to start my career over again, if I was 25, I would go into the stop loss business because they really, it's incredible the opportunities that they have. But stop loss is becoming more difficult and more difficult to manage. So we have actually a stop loss coalition, much like the pharmacy coalition we developed, where we're taking all of our clients and we're going to the largest carriers and saying, here are our terms. And with stop loss, I think the couple of things that you want to make sure is that pharmacy is included and that you have 100% mirroring provision in your contract so that if your stop loss is handled by an independent company, somebody other than your carrier, they are agreeing to match your medical carrier's benefits. And the reason I say that is because there's a lot of stage 3 trial drugs that stop-loss companies are excluding from coverage because they're not approved, FDA-approved drugs yet. They're in the clinical trial stage. So you have to be very careful and just make sure that when you're negotiating, you're looking at the lasers, you're looking at the terms in the contract, such as 100% mirroring provision, and things like, carving out stage 3 trial drugs. I mean, that's just not fair. So anything that's covered under your medical should be covered under your stop loss. And specifically to answer the question, there's those stop loss premiums are going to continue to increase as the cost increases, right? Because they're still going to want to make a profit on those and protecting you in that insured arena for large claims.
Another question that came in was if you have any thoughts or projections about what kind of ripple effect with United Healthcare's withdrawal from the public exchange.
I think, if you read some of the articles, I think it was, they had stated earlier that they were going to look at each market and try to figure out which ones they didn't think that they would become profitable in. I think there's definitely going to be a ripple effect with the other carriers, because now if you think about it, if United pulls out of a particular market where they were losing a lot of money, those participants are going to go to one of the other carriers in the public exchange. So they're going to be losing money because those are obviously the sickest heavy utilizers in that population. So the thing that worries me is if you look at the population in the public exchanges, 60% of them get subsidies so that their cost is around $100 or less per month. And we know the coverages cost between $800 and $1,000 per month. So that's a heavy tax burden, right? So in order to keep that exchange viable, they're going to have to do something with who's paying for it, and that's the taxpayers. And the employers, quite frankly, through taxes like the excise tax, the quarry fees, all of those, the fees that we thought were one-time fees may not be going away.
Awesome. There's a lot more questions actually that have come in, and we unfortunately won't be able to get to all of them, but I can assure you that Marybeth will reach out and be in touch with you individually regarding the questions you've submitted. Thank you so much, Marybeth, for this amazing webinar today and all the information. We really appreciate it. We're going to go ahead and sign off. Thank you, audience, for joining us. When we close, there will be a quick survey that pops up on your screen. If you don't mind going ahead and answering those just 5 quick questions, we really appreciate it. Again, Marybeth, thank you so much. This was fantastic information.
Thanks, Kelly.
All right, everybody have a great afternoon.
Thank you.